Welcome everyone to today's webinar, How to Hit Your Value-Based Care and 340B Drug Discount Targets. My name is Ayla Ellison, Editor-in-Chief with Becker's Healthcare. On behalf of Becker's, thank you for joining us today. Before we begin, I'm going to walk through a few quick housekeeping instructions. We will begin today's webinar with a presentation, and the panel will have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you don't see your slides moving or you have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We are here to help. With that, I am pleased to welcome today's discussion panel. Tim Groninger is Caravan Health CEO and President, and he'll be joined by Terry Hill, Executive Director at Rural Health Innovations and Founder and Senior Advisor for Rural Health Leadership and Policy at the National Rural Health Resource Center. Jason Shriver is the Vice President of Ambulatory Operations and Population Health at Fisher-Titus Medical Center, and Dr. Christina Taylor is the Chief Medical Officer at McFarland Clinic. Tim, Terry, Jason, and Christina, thank you for being here with us today. I'll now turn the floor over to you, Tim.
Great. Thanks very much, Ayla, and thanks everyone for joining us. Really happy to have the opportunity to talk with you all today. There are thousands, hundreds of thousands of topics we might chew on for value-based care success, and we have a lot of resources available at our website if there's anything that we're not covering today that you're interested in. But I wanted to focus today's discussion on a few key pillars or a few key use cases or scenarios that come up frequently over the last few months. And that is how rural providers can participate effectively in value-based care programs in the Medicare Shared Savings Program. How physician leadership is handled effectively in these types of initiatives in value-based care in Medicare and in other payers, and then what 340B covered entities might be able to do to take advantage of the workflows and the data that they have available in value-based care programs to claim more of the discounts to which they're entitled to support their operations as safety net providers. Our organization and agenda for the day, we're going to start off with a quick introduction to Caravan Health and how we approach this work. You've already met our panelists, and I thank them for joining us today. And we'll spend some time on the ACO business model, on how we organize ourselves to succeed in clinical initiatives, operational excellence, and financial success. And then we'll take some deeper dives into those three perspectives that I mentioned just a moment ago, to get perspectives from providers and physicians and a physician who's doing this work, as well as a rural health expert who's looking at trends across the country in rural health. So jumping in with an introduction to Caravan Health. We are a technology and services company that helps providers across the country succeed in value-based care programs. In particular, in the Medicare Shared Savings Program, we are working with more than 300 health systems over the last couple of years, tens of thousands of physicians in thousands of practices across the country. Our ACO clients have generated more than $120 million in shared savings payments to them as participants in these ACOs in the last 2 years. And our collaborative ACO structure, in which providers who are not owned by or even necessarily affiliated with one another, but come together to do the work of prevention and care management and ACO performance, those collaborative ACOs are 100% of the participants in those ACOs are on track to generate shared savings for the last cycle. So we are very proud of the performance of the providers that we are working with. Every one of them has very meaningful stories of improvements in patient care experience that go beyond the quality metrics of the program. People who have been able to avoid frequent visits to the emergency department, patients who have gotten their blood sugar under control in ways they never were able to before because of the investment in primary care that you can do with these models. And I look forward to hearing more about that from some of the participants here today. just thinking about the why here, and why some of you all tuned into this webinar, and why many of our clients work with us. Healthcare providers are under constant pressure from all sides, from the payer side to keep rates low or to keep rates from going up at all ever. Their costs increase every year, wages go up, raises have to be made, vendor costs, technology costs go up. And so successful leaders in healthcare organizations are constantly looking for new opportunities that arise to generate new revenue and to improve the care delivery experience for their patients. Because that's why we get into healthcare, and that is why, and that is what it takes to continue to grow and to sustain your organization and to keep patients coming back. Value-based care is one such business model opportunity that gives providers who take the time and energy to do this well the opportunity to generate new revenues from doing the right thing, rather than, as one of a client put it, doing the right thing to ourselves out of business. We see this as organized around three key pillars for success. And if you don't perform on these three, then you aren't going to succeed in these models. Obviously, have to get the clinical workflows right, have to get the clinical initiatives straight. That includes staffing, that includes training, that includes implementation of tools. You need to, that needs to be operationalized correctly so that it's not just a good idea or something that we would like to do for our patients, but we can't actually deliver on. And then we need to line it up to make sure that revenue is actually being generated from these initiatives. And so that's certainly generation of shared savings over a couple of years time period, but it's also being creative about making sure that we are hitting our coding targets, because that's going to generate shared savings down the road. It's about generating new preventive care revenue and care management revenue, perhaps even just documenting work effectively that you weren't documenting effectively before, and keeping track of the right amount of time. For 340B covered entities, there's also very significant revenue generation opportunities from population health work. And we're going to talk more about that as we go on to this presentation here as well. So you got to get the business model right, or none of the other stuff is going to work anyway. In the business model, just in very broad strokes, that the way we look at this with a new initiative, this will vary for any individual client setting and for depending on whether you're rural or what sort of your payment system you're in. But generally speaking, we want to be targeting producing $150 per patient in shared savings per year. We want to generate population health revenue through more preventive care, annual wellness visits, chronic care management services, a few others, $75 per patient per year. If you're a 340B covered entity, you can very straightforwardly, over the next couple of years, identify another $100 in discounts that you are missing. We see 80% of the 340B discounts going missed in the data that we look at with our clients. And then if you are in a PPS or the physician fee schedule payment model, I should say, or system, then you can be looking at some benefit from being in an ACO for APM or MIPS payment purposes as well. I'll call it $50 here. To do that, to generate that revenue, you have to invest in some staff time and invest in some technology and some work with Caravan that, for instance, to help us, we will use that to train your staff, for instance, on how to do this. And you can generate, if you are a 5,000 life provider, aim for $300 in net annual incremental income, or $1.5 million for a 5,000 life provider. That's your target. That's one way you can look at organizing yourself when you jump into this model. There's a lot of pieces to execute effectively to realize that revenue, but that's what we can help with. One other point that it's really important to keep in mind for that 5,000 life provider, and why we think it's usually a mistake for even a medium-sized IPA or health system to do this on their own. If you join an ACO as a 5,000 life IPA or ACO, you are going to have massive variation in the performance of your ACO in any given year. And this is particularly acute problem for rural providers, where you aren't even large enough to join an ACO if you have just a few primary care docs that you're working with. But even if you're working with 20 PCPs and you can create a 5,000 life ACO or a few thousand life ACO, your spending against the benchmark is not going to be measured in a way that makes any sense statistically. And that's something that health insurance actuaries have known forever. If you look at the performance of ACOs against the benchmark on the right side of this chart, though, where you're looking at larger ACOs, you see that all of them are within 5 percentage points of the benchmark, and almost all of them are beating the benchmark. That's why we have created large national collaborative ACOs. This is what, for anyone who's in the situation where you are considering whether you have to leave the Track 1 ACO program because you're going to be required to join risk in a Pathways ACO within 1 or 2 years of joining. This is a question you can be asking yourselves is, do I have a risk-sharing partner, or is there a collaborative ACO that I can be looking at? Because that is one much safer way to join, much less likelihood of writing a check to CMS, much greater likelihood of generating shared savings. So that scale is one of the key pieces of our model. But taking a step back on the strategy of how to implement this, this is organized first clinically around primary care. You need to be staffing up and wrapping your primary care clinics with love and attention, making sure that you are providing the training to your staff that's necessary, making sure that it is staffed adequately, and that they have a technology infrastructure that they can use to actually do this work. You need a governance and change management plan to oversee progress in this effectively, to make sure that your multiple primary care clinics are all swimming in the same direction and that you're tracking progress with key performance indicators and scorecards and tools to roll that up. And you need to support this with a data and analytics and workflow accountability engine that is not just pushing paper and that is not just relying on one staff in project management to keep things in order. You need to have visibility, and you need to use the claims data and your clinical data in a way that is going to drive success for your organization in a sustainable manner, not just in an ad hoc manner. We support this approach with regional teams organized around our client practices. So a regional vice president or someone in charge of making sure that the progress is moving forward. Practice transformation specialists, a clinical leader, what we call an experienced nurse, and an improvement manager who can support your team in implementing new prevention and care management workflows. And then bringing in subject matter experts in quality reporting, quality improvement, physician support, data and analytics, whatever is required for the ACO to improve and to succeed over time. And we coach to a team-based care model that is organized around helping our clients as much as possible think about work that can be taken off of the plate of physicians and handed over to staff that can be doing the work and providing the services and the care under the supervision of physicians in a way that can be billed for. This also will vary significantly and is very customizable to any particular client environment. The way this works in a critical access hospital and a rural health clinic will look different from how it works in a large multi-specialty practice. But the core piece of it is being thoughtful and explicit about how we deploy resources and making sure that we are generating the revenue that will pay for those resources through shared savings as well as through new preventive care revenue dollars. This one may not be what you would normally expect when you log into a value-based care discussion, but we've found a huge synergy between effective management for patients with very high-risk medications and capturing discounts that are eligible in the 340B program. Most of our clients, the vast majority by far, are 340B covered entities. Rural health providers almost universally are 340B covered entities, as well as safety net facilities in urban areas. The short summary here is, without going through this whole thing, most safety net providers that we have looked at the data with are missing 80% of the prescriptions and the discounts for which they are eligible. And that's even in effectively managed systems with efficient and good TPAs, third-party administrators. The reality is that you don't have, unless you're looking for it, you don't have great visibility into what's happening for referrals happening outside your network, and making sure that patients are being managed in-house that are seeing specialists and receiving very significant medications there. So combination of workflow interventions and data can generate the opportunity to eat into that 80%. And Jason Shriver is going to talk a little bit about his experience in Fisher-Titus on that topic in a little bit here. On the rural ACO topic and rural provider topic, we all were expecting a significant program out of CMS this year to support rural providers in joining ACOs. And it was building on a very successful innovation center model from a few years ago, where CMS provided forgivable loans to join and participate in ACOs. And it generated very significant returns for Medicare. It also generated very significant shared savings for many providers who were joining the program or who participated in the program. CMS pulled back on that and said that they're going to delay it for a year. We at Caravan Health, I just want to get in a plug here, are going to step into the hole and provide the loans that CMS has withdrawn from the year. So for anyone who was looking to do this program and is interested in joining an ACO and having access to all the tools and all the data that I've described and that you're going to hear more about, we are going to be making that program available for free with no downside performance risk for ACOs in this program. For anyone who's interested in that, it's a great opportunity to generate significant incremental income for rural providers while implementing some really important population health programs that are tough to implement on your own in rural spaces. So we're excited about this, and we're happy to bring this to market. And we are going to dig in deeper on rural topics and rural health innovation here now as I hand it over to a longtime friend of Caravan Health and just a really thoughtful guy in rural health, Terry Hill.
Thank you very much, Tim, and it's a pleasure to be here. This is my favorite topic. I'm with the National Rural Health Resource Center, and part of our responsibilities is to identify what is happening in rural ACOs and other value models, and basically identify what lessons learned, what have we learned here, and then try to spread that knowledge nationwide. Next slide. I want to share this slide with you because one of our projects last year was to work with the Mayo Clinic to identify where are rural hospitals and rural clinics going to be in 2030, particularly if the trends continue. And we basically, as part of that project, kind of employed the Stroudwater Group to help us identify what was going to be happening, and if the current trends, particularly financial trends, continue, what were particularly Minnesota hospitals going to be looking at, like in 2030. And what you can see here is that this is MedPAC's report in 2019 showing a gradually worsening of Medicare margins for hospitals pretty much nationwide, but particularly for rural hospitals. And so, you know, we talk about this concept of risk, but if these trends continue, there's huge financial risk, kind of continuing fee for service and keep doing the same old thing. Next slide. And this is just, I threw this in, most of you probably know that, but it's kind of the value-based continuum. And all of the payers that we've been able to identify, Medicaid, Medicare, and private insurance, are pushing our providers as much as possible into to the right here, into ACOs with risk. There's a new program out now through CHART that talks about a global budget, et cetera. But our observation is that we're moving towards some sort of an element of total cost of care. And then in essence, the ACOs may very well be an important step forward, but we're not sure exactly what the payment is going to be in 2030. What we're sure about is that we really have to be prepared moving in this particular direction, and the ACOs are a great place to be at this moment. Next slide. And when we look at that, we see this historic trend versus this value payment. You can see as we went out for the next 10 years or so, just taking the Minnesota hospitals and looking at their financial situation, our conclusion was that if things continue and these trends continue, the Minnesota hospitals, at least about 3/4 of them, would be in very severe financial difficulties down the road. What you see as an alternative is moving more towards this capitated payment that's an accountable care organization, for example, or a global payment, et cetera. That's one way to stabilize the cost. It has risk, but my comment is the other fee-for-service has even more risk. Next slide. So what are the advantages? I don't even care about the disadvantages. We know, I've been working in rural hospitals for 30 years. We know what they are. But we now see a current funding available through CHART for strategic investments and advance payments. And if we're going to postpone this for a year, it's great to have an organization like Caravan's willing to take on those responsibilities to help us get the infrastructure in place. Our rural health is primary care based. That's a huge advantage. Primary care providers at the heart of these value-based models. And we're basically not having to deal with subspecialists who may very well stand to lose money in this transition to value. Rural health is more community-based, and we've really got to be thinking about that because it is one of the keys to being successful down the road here. And finally, and I think most importantly, and I think this is something that Caravan has really demonstrated, is our rural health delivery systems can change more rapidly than urban system. It's kind of like the movement towards the iceberg. The great big systems with tons of specialists and subspecialists have taken a long time to turn, and we think it's an advantage for rural providers to be in a situation where they can do it much more quickly. Next slide. What have we learned? And we're going to talk a little bit more about this. Physician engagement and partnerships are essential to ACO success. This is not only rural, but it's urban as well. We've got to get the physicians on board. And if you are in the early stages of an accountable care organization, it's absolutely essential to get the docs involved. Behavioral health is costly. I'm going to show you a slide a little bit later on this, but it's one of the areas really to focus on. Post-acute care is an opportunity to reduce costs and improve quality and satisfaction. An example of that is the Illinois Critical Access Hospital Network's ACO identified post-acute care as one of their major both cost problems and quality problems in that regard. So we've got to be thinking about that. A lot of this post-acute care is going to go into the homes and into telehealth, I would suggest, instead of a lot of nursing home care here. Access to comprehensive health information is absolutely essential, and that includes not only the access to the information itself, but the ability to analyze it and to use it for improvement. Community engagement and partnerships should be done as early as possible. And we're going to see that there's lots of opportunities here if we're going to be doing wellness visits, which we should all be doing because there is revenue, I assure you, in these wellness visits and an opportunity to basically stop out-migration for care and to really start to, if we're going to reduce our inpatient costs and revenue, then in essence, we're going to have to improve that outpatient care, and working with the community is just an important place to start. Next slide. This is just an observation here. This is, and I think a lot of the Caravan data that I've seen at least really corroborates this. If we have, this is the cost of behavioral health when it's combined with a chronic illness like diabetes, for example. The cost here multiplies 2, 3, sometimes 4 times if that person with diabetes also has a behavioral health issue. So really drilling down into behavioral health and finding ways to make partnerships with your community mental health providers, really starting to look at the possibility of telepsych and telebehavioral health is absolutely a great idea as soon as possible. Next slide. And this is kind of my favorite slide, and that is hospitals and clinics all have the possibility of partnerships with each of those community providers and community folks. And there are examples of really outstanding partnerships with faith-based organizations. For example, we've identified nationwide in the area of emergency services, community paramedicine is really emerging here as a source of revenue as we're opening up new revenue areas, and also just as a really great way of being part of the care delivery team. It's going to be essential to work with the businesses as well. And so we just strongly recommend developing those partnerships just as soon as we possibly can. Next slide. And this is my final slide. And this is, this really gets into that whole concept of risk. Even if you're on the right track, you'll get run over if you just sit there. To me, being on that track and not doing something at least to prepare for value is the riskiest thing that I can think of. So with that, get my final slide. And this is my contact information. I really invite any of you that might want resources or anything else that we could provide at the center to let me know, and I'd be happy to send it to you. Okay, I'm going to hand it over now to Jason Schreiber, who's going to tell us a little bit more about 340B.
Great. Thanks, Terry. Great. I'm going to talk about Fisher-Titus and our journey to 340B and how we're going to expand it to our ambulatory locations. So a little bit about Fisher-Titus. We're a not-for-profit healthcare system. We're a rural health provider. I like to call us rural health light. We're right in between Cleveland and Toledo. So we do have a decent amount of clinical talent coming out of our area in Norwalk, Ohio. We're a physician leadership. So our CEO is actually a hospitalist by trade, very transformational leader. So as we go through a lot of the changes in a value-based environment, having that person be a physician really helps with the change management component. We're a healthcare system. Like Terry mentioned, we actually have our own ambulance service. In addition to our medical center, we have an employed medical care group, a skilled nursing facility, and our own home healthcare agency. So we're small, but we're very complicated when it comes to the services we offer. It's an advantage because we can really look at the different cost levers as well with the delivery that we're providing. 250 providers on staff. Like I said, we're employed, but we also have some community physicians as well. 1,300 employees and then 17 medical offices. The backbone of our medical care group is really our primary care base. So they make up over 60% of our providers. In addition, we do have some special subspecialty providers like urology, digestive health, general surgery, women's health, and a pretty robust peds practice as well. Next slide. So I really like this picture. This is a saying from a prior colleague I used to work with. He goes, shifting from fee for service to fee for value is like changing the transmission in a moving car. The reason I picked this picture as well from Tommy Boy is that the movie was actually filmed in Sandusky, which is about 10 minutes from Norwalk, Ohio, where Fisher-Titus is. So great movie. Next slide. So our strategy really consists of 3 different buckets in ambulatory. So system integration. When I joined Fisher-Titus, we had a lot of independent medical practices, really weren't efficient. So one of the things that we've really been focusing in on is the overhead and the administrative cost around referrals, phone calls, prior authorizations, things of that nature. Network integrity. So where can we deploy services closer to patients and into the primary care clinics? You know, we're looking to deploy cardiology. We're looking to really build a patient-centered medical home around our primary care docs to keep care close to home and within our umbrella. Visual management, this really gets into continuous improvement, productivity, and just really doing the things from a management standpoint. Our second bucket is around value-based revenue. Tim hit on a lot of this. We have 2,500 attributed lives as far as Medicare goes. So being able to work with Caravan Health has been great as far as being able to join a larger ACO that really predicts the risk and really predicts savings for us. We also work with our CPC Ohio Medicaid programs that covers adults and children. And then our employer self-funded insurance plan. Fisher-Titus itself is self-funded, so making sure we're managing the cost and utilization for our own employees is key. And then the third bucket, which I'll get into more, is 340B program expansion. So really looking at three different buckets of revenue and patient opportunity around prescription drugs. Employed providers, these are really under our covered entity, and those are prescriptions that are prescribed through our EMR. External providers, those are the community physicians that we work with, and then no attributed provider. And these are patients in our ACO that have not had any contact with a provider from an E&M standpoint within the last year. This is a huge opportunity for us. Next slide. So just the background on 340B, if you're not familiar with it, it's no cost to the taxpayer, it's funded by pharma, and it's no cost to the patients. Those are some of the key pieces of 340B. It's been around for some time now, but it keeps expanding year over year, and different opportunities have come up specifically for rural healthcare providers. Next slide. So a little bit about our journey. We've been doing 340B on the hospital side for over 4 years now. We've recognized a little over 1.5 million in shared savings back to our entity. One of the things that we really wanted to look at moving forward as reimbursement shifts and care settings shift and insurance companies really start to drive patients to different places of care was how do we offset revenue or bring more revenue in. So one of the things that we were looking at is expanding our 340B program to our ambulatory locations, or what we call child sites. One of the caveats, though, to being able to expand the program is you have to be provider-based. So that means the professional, technical, and being HVAP or Joint Commission certified. So that's something that we had to do, put in place, put a lot of policies, a lot of facilities changes in place to get to that point. Next slide, please. So those three buckets that we mentioned, like Tim said, it's really just doing the right thing. So when you look at prescriptions written by an employed provider, this is just managing hemoglobin A1C. All right, what prescriptions are you looking at? Januvia, that's one of our biggest ones. There's opportunity to get pay for performance dollars for doing the right thing and then capture the revenue on the back end. Prescriptions written by a referred physician. So we have a lot of community physicians in our healthcare environment. We actually do some reverse engineering here. So you can look at where you have some opportunities with your specialist and say, hey, this patient could potentially actually be under a covered entity as well. And then the third bucket is the ACO patients. And this is actually the second largest bucket of opportunity for us from a dollar standpoint. And this is, from a care delivery standpoint, this goes back to, PCMH, medical home, really establishing a different site of care to deal with these patients and get them in and get them established so that you can capture some of that revenue. All right, I'd like to hand it off to Dr. Taylor. Oops.
Well, hi there, everybody. My name is Christy Taylor. I'm an internal medicine physician, and I've been in the value care space for a long time. I was previously a chief quality officer, and I'm newly the chief medical officer at the McFarland Clinic. McFarland Clinic is in central Iowa. We have over 200 providers. We see over 98,000 primary care patients. We have over 40 specialties, so we're multi-specialty, and 25 offices. We have had some considerable success in the last several years in value-based care. We started out in the commercial world, and we're in a part of a commercial ACO, and had considerable success with shared savings over the last several years. And then most recently, we've been part of what's called the Stratum ACO. It's one of the Caravan ACOs, and we are grateful to also have strong performance in the Medicare Shared Savings Program. We have consistent high quality measures and shared savings. So I'm really here today to just talk to you about the various components of how can you be successful in a value-based plan, in a Medicare Shared Savings plan, and also, frankly, a commercial plan. There's some key components that we're going to discuss here today. So, you know, really, it's kind of like building the legs of a stool. And if you don't have one of these legs, if there's something that you don't have, it's not going to sit right and it's going to fall apart. So these are what I consider the key components. And one of those, the first and foremost, as it's been said by more than one person here today, is you really need to have provider engagement. So I don't know about you, but it seems like lately we have a lot of meeting fatigue. We have a lot of people who, you know, COVID's been a bad year. So, you know, we really kind of want to go from to people super excited to, you know, do well in their ACO and go to more meetings and get this right. I'm not sure that we can expect to get to that. That's probably a little bit of too much to ask. But frankly, what we're really looking for is, can we just have people say, I'm here to put patients first and be part of a team and make this better? I think that's a realistic expectation, and that's what we see if we try to get and keep our provider engagement. This is the kind of teamwork that you get when you put the energy into it. So I don't know about many of you, but I have to worry about this all the time. We always have the physician or certain ones who, you know, before they do anything else, before they commit, they're asking, what's in it for me? So I think you go ahead and shine a light right on it and say, we need to talk to the physicians, the providers directly about what's in it for you? Why would you change? Because we're asking them to change their practices, to change their behaviors, maybe to change their time of day, their site of service. There's all sorts of things we're asking them to change, to do more, to give more. What's in it for them to do more and to give more? So I think you have to look at there's various strategies in the what's in it for me. This is an example of something that I did with my physicians recently when I was trying to say we need to be taking blood pressures clinic-wide. I actually showed an example of there's lots of other places around the country who have been doing this for several years now. This was one thing that we were, frankly, a little bit further behind some other clinics. And so nobody wants to be a C student. Nobody wants to be the last one on the train. So use that to your advantage. When you know that other great places are doing something and they're considered high-performing clinics or organizations, and you're not doing that yourself, use that. It helps. You know, becoming part of a collaboration, doing things with other clinics and other organizations can be very helpful, whether it's being part of the Million Hearts Challenge or, you know, whatever organization that you're a part of, whether it's AMA, AMGA, GPIN, et cetera. Being part of collaborations that share best practices can be very helpful, and it gets people excited when they know that they're not only going to be doing a project themselves, but they're going to get to learn from their colleagues at the same time. And then, frankly, when it comes to doctors, you really need to show them what's in this for patient care. Is it the right thing to do for the patients? Because thankfully, there are still most of your doctors who want to know, is this the right thing to do from a patient care perspective? So you need to always have the look of what's right for the patients at all times. Last but not least, you need to align your incentives. We have not a policy, but we have a program here where we do distribute our shared savings. It's a little different every year how we do the distribution, but physicians are involved in those discussions. Physicians are involved in those decisions because we're a physician-owned and physician-governed group, we take a look at how can we use some of our shared savings dollars to align our physicians with the behavior change that we're trying to get. So whether you are part of a system where you have employed physicians or whether you have just partnering physicians, I would strongly encourage you to align the incentives properly, which means that you need to be having some sort of carrot financially to encourage the sort of behavior change that you're looking for. This is one of my favorite slides because I think we all say, you know, you can go from bottom up or from top down. This is a reminder that the only way you are going to get physicians, particularly physicians, not just all providers, but physicians in particular, the only way you're going to get true buy-in is when you have them in on the ground floor. So I would strongly suggest that even if you're, you know, your CEO, your chair of the board, your hospital administration has a program or an initiative that they want to move forward, don't just have a key token physician on the committee. You need to have lots of physicians involved, as many as possible. As a matter of fact, they should make up the majority of the committees. You need to start from the groundswell and move upward, because that way you'll make sure that the patient's needs are put first and that you have better buy-in from the physicians from the very beginning. One of the next legs of the stool that I think is super important is not only having data, we all know that data matters, but actually taking a look at it and reporting it frequently. If we aren't measuring something and aren't reporting it out, nobody's going to pay attention to it. So it's super important that you show data that's meaningful to your providers. It also has to be something that's actionable. If this is nothing that they can change or improve, why are we showing it to them? So it has to be measurable, meaningful, actionable, and then we need to be putting it in front of them in some sort of regularity, whether it's once a month or once a quarter. I think once a week is probably too often, depending on the initiative, but monthly or quarterly data is usually good for a physician. There's another word that's actually supposed to be on this screen, and you can't see it, but it's the word transparent. Your data needs to be transparent. The more transparency you have, the more buy-in you will get from your providers. At our organization, we show data rather unblinded. Unblinded, transparent data is the most powerful type of data that you can share with the types of people who are used to seeing data. They order labs, they order images, and they're used to seeing everything. They don't want things held back. So showing data transparently can be very powerful. I'm showing a couple of examples here, not because I want you to read what's on the screen. The numbers on here aren't important, but this is an example of the type of report that we share with our physicians monthly. So I've got the names and the scores grayed out here. They're redacted, but you can see each one of these horizontal rows is a separate physician. And then they're shown how they're doing compared to their peers. And this is a commercial ACO and the data points of various quality measures in the commercial ACO. So they do things very colorfully on purpose. Green is good, red is not meeting target, white is sort of meeting target, but we put these in front of people monthly and they get to see compared to their peers, how are they doing? And then at the organizational level, if you kind of stand back and squint at this sort of picture, you can see if you have an entire vertical column of something that's red, then that probably isn't an individual physician issue. That might be more of a system issue or a process issue. And that, that's something that if everybody is struggling with something, then there's maybe something that we need to be doing at the system level to affect this quality measure. This is just another example of a transparent type report that we use with our providers. This was something that was super important to us, and that was to get on top of opioid prescriptions and make sure that we were using the proper things that we need in place to make sure that we're doing opioid prescriptions appropriately with pain management agreements and those sorts of things. So the people who are in the green were following the protocols that we had set in place. And if you weren't in green, then you can see transparently to your peers that you were maybe an outlier and weren't following the protocols often enough. So putting these things in front of people is what got people to move, and they moved pretty quickly. So transparency works. Moving on to another leg of the stool. This slide is just to represent the fact that as a healthcare organization taking care of a population of people, I really liken it to being a shepherd. Physicians are now supposed to work as a team, but as a team, you with your nursing staff, your care managers, what you are doing is you are shepherding your population. And some of them are already going the direction you want them to because they're very health literate and taking care of themselves. And some of them are just scattered about. And it's your job as a team, led by the physician, to help move these people in the right direction. So what does that mean? Most of us know we use the words care management. In your organization, you might call it care coordination, care navigation. Essentially what it is making sure that we're caring for populations of people. You can do outreach to various patients. The smart outreach is to the people who need it the most, the people who have a vulnerable time in their life, such as a transition of care in or out of the hospital or the emergency room, versus vulnerable patients, and those are specific disease cohorts, or people who meet certain social determinants of health, and we're just beginning to get into that. If you narrow your focus and you use your claims and EMR data, you should be able to also find people who have higher utilization. And these are people who need more hands-on management. So you're never going to have enough care managers to say we can reach every single person and do person-to-person care management. So you need to find the people who truly need your nursing resources. And usually these are people who have high utilization, maybe readmissions, or they might be high-cost patients without a particular reason why. And then it's up to you as the organization to say, why is this patient having high cost if we can't explain it based on a certain diagnosis? Chronic disease management, of course, is a key function of our care managers and part of the reason why we believe that we're successful in our value-based care efforts. So in going from how do we reach out to a population and versus an individual, you're going to do a lot of automated type outreach. This is messaging through your website, your portal, your social media. Those are your larger types of outreach. And then you're going to save your human resources, as I've said, where it's most needed for that, the patients who have high utilization, high cost, or they have chronic diseases that are not in control. That's where you're going to use your most valuable human resources, your care managers. Finally, Tim mentioned this earlier, but it's super duper important. You need to train your providers about risk adjustment, and that's HCC coding. Everybody needs to understand that this is the foundation to financial success in the value-based care world. Not all patients are alike, and if we don't put in the proper HCC codes, we don't get credit for how ill our population is. This is something that it takes a considerable amount of time and energy to explain and educate to physicians who are new to this concept. But it's worth every minute that you spend. And once you have people understanding this, then everybody sort of gets in sync to wanting to make sure that they're getting the HCC codes put in every year. So you should be able to walk around as an administrator, as a physician leader, you should be able to walk around to your physicians and say, can you explain to me why HCC coding is important? And if a provider can't explain to you why it's important fairly succinctly, then you know you have a little further education to do. Finally, the last leg of the stool is really one that we all understand well because Medicare costs are going up. And this is all about cost reduction. So, you know, in the old days, we spent a lot of money on just whatever we thought we needed to do. And in the new days, we have to take care of more patients, and we have to do it with less money. So we have to have, 2 stools, 2 chairs. They need to be good quality, but we need to be seeing more people and providing better quality, and frankly, with less resources. So, how do we do this? As I've said, you need to engage your providers at every step of the way. You need to engage your providers in the cost reduction efforts as well. Get them to be creative. Ask each specialty department to figure out how they can keep people with diagnoses that are relevant to their specialty, how they can keep those people out of the ER. How can we avoid admissions? Do we need to have a different site of service that's maybe a lower cost for our patients in the system? You've heard about a system today that can result in lower prescription drugs, but you need to have just basic systems in place whereby people are automatically using generic drugs or the lowest drugs that are the most cost effective. Advanced care planning, palliative care are things that are a little bit more advanced, but at least having discussions with your doctors about talking to the appropriate patients about advanced care planning, that's something that you will need to be doing before you're at downside risk. Super important. And then eventually we need to get to where we are addressing the social determinants of health. This is something that's a little bit difficult to do. You don't necessarily have the capitated funds to do these things first. But once you get to the point where you're starting to take downside risk, we definitely need to be addressing food insecurity, medicine insecurity, so the ability to fill their prescription medications, transportation to and from doctor's appointments, those sorts of things. Will take some creative solutions, but those are the things that you need to start working on in your organization. So these are going to take time and effort. Everything I've talked about is something that does take time and energy and resources. It's not easy to get into value-based care. It is necessary, but there are some costs up front that involve both time and financial resources. So work together between your hospitals, your doctors, and figure out what do we need to put in place first, second, and later to get these things rolling. So that's really the end of my presentation today, just trying to give you some hints and tips at how to be successful in the value-based care world. And I've said it before, I'll say it one more time, make sure that you involve your staff, your providers, as well as your nursing staff, and making sure that they are involved in decisions from the very beginning, not only to build buy-in, but because that's how you'll keep patients first, and that's where you'll get the most creative solutions.
Thank you so much, Dr. Taylor, for that, and thank you to all of our other panelists for a great presentation today. We will now begin today's question and answer session, and you can submit any questions you have by typing them into the Q&A chat box on your webinar console. So we've already had questions come through, so we're going to go ahead and get started with the first one. And the first question for our panelists today is, how has the pandemic affected ACOs and their ability to implement population health management programs? And I'll just open that up to whichever panelist wants to weigh in on that.
Well, I'll answer. We've spent a lot of time talking to our clients and ACOs about just this, and it's does not lend itself to a short answer, but suffice to say, in just about every way imaginable, and in some ways not at all. So the core of ACO work is being that shepherd of your patients, that, as Dr. Taylor described, and organizations that had built care management capabilities before the pandemic were much better positioned to be able to ramp those programs up and switch it to virtual and telehealth as compared to organizations that hadn't done any work in ACOs at all. And so while it certainly necessitated a lot of changes in how we worked with our clients and how our clients were working with their patients, I think that the providers in ACOs certainly working with us, but generally across the country, I think managed much better than those who were having to figure it all out all at once from scratch, essentially. welcome other answers from panelists as well.
I would add that there's a huge advantage that was gained here. Just, we have so much going on in this area. It's been so difficult for rural hospitals and clinics, but the telehealth, the loosening of the regulations and the payment now for telehealth has just been a huge advantage, and we're expecting that to continue. So I think we can use telehealth more effectively in our accountable care organizations. And that's been a huge burden just in terms of, for example, home care in rural areas is so difficult to provide cost effectively. And now telehealth has opened a lot of different opportunities.
Thank you both for your insight there. We've had a few more questions come through, so it looks like we have time for a couple more before the top of the hour. So we'll go ahead and move on to the next question, which is, how does Caravan help its ACOs get ready for risk?
Sure. And I will also note, I see a bunch of technical questions on the 340B program coming in to the Q&A as well. And we will not be able to get to all of those, but certainly happy to discuss them one-on-one. If you want to just email us at info@caravanhealth.com, we will get back to you and set you up with one of our subject matter experts. We'll be working with a number of clients in risk-bearing ACOs over the coming years, and in some higher risk tracks as well in the Medicare Shared Savings Program. And to us, the key pieces there are first performing in the program at all. The rules aren't different in a risk-bearing program, other than if you do badly, you have to write a check to CMS, which is a very significant difference, obviously, but there's the measurements work the same way. And so we want to demonstrate success in the non-risk track in the first year before moving to risk-bearing tracks in the second years and beyond. And then the other piece of it is we, Caravan Health as an organization, will take most of the downside risk of the performance for the ACO on the basis of the performance and experience we've had. We feel comfortable absorbing that for our clients because we believe we can minimize the risk of writing a check to CMS.
I'll add a tiny bit to that real quick here. I think the other way that Caravan helps an organization get into the risk-based world is by providing what I would call logistical and organizational assistance. They kind of come in and show you your data and walk you by hand. If you're an experienced organization and you've been in a risk-based contract before, you might not need that, but what they really do is not only show you your data, but then they show where you have opportunities. They teach you about annual wellness visits and care management and show you where you have opportunities to reduce cost. And so they really sort of help you analyze your data and show you where you can go to work.
Thanks for that, Dr. Taylor.
Yeah. Thank you so much, Timmy and Dr. Taylor. It looks like we have time for one more question today. And this question, or this attendee wants to know, we tried an ACO a few years ago and we lost a ton of money. Is it really worth trying it again?
Well,
I'll
absolutely.
defer to Jason and Dr. Taylor on that one. Yeah, go ahead.
Yeah, absolutely. Nobody's ever going to have a winning year every single year. The statistics are somewhere between 1 in 7 and 1 in 10 years. It's just going to be a losing year. So, but that also means, 6 out of 7 years are going to be good years. So I frankly think that this is a train on the track that you can't avoid. You're going to have to move that way anyway. So the sooner you get in, the sooner you will start getting better at it.
Yeah, I agree with Dr. Taylor. We've been in our ACO or with our partnership with Caravan Health for coming up on 5 years, and it's really an investment, and we've really started to see the return on investment over the last year or so. So it's something that's not gonna happen overnight. There's a lot of moving parts, and you have to be patient, but you have to do what's right for the patient ultimately. So we've had great experience. Like I said, some years we're down, but we have the momentum, I believe, moving forward to continue to see return on investment.
Thank you so much. And that is all the time that we have for today, but I want to thank our speakers for an excellent presentation and Caravan Health for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you for joining us today, and we hope you have a wonderful afternoon.
Thanks a lot.